My name is Chris Proux, so I am with Medray. So I do education, strategy, and work with clinicians as well as our partners, our dealers and distributors, and things like that. And so, like I said, this was something coming out of our education. So this is a monthly webinar series that we do, and so we did one in January. You can go back and you can review these. They're all recorded and they're on our YouTube webpage. So this is sort of that continuation. So last month we sort of talked about, well, what happens when things stall, maybe why they stall, and one, reducing that from happening, and two, what can we do to remedy the situation. And so we're kind of moving forward with that and really looking at parameters to protocols as I say, because there's been a bit of a shift. Like even when you look at the literature and how, a lot of the things that we do in conservative physical medicine has been evaluated, there's a large emphasis on pain. And so, we hopefully are moving away from that a lot, not only in terms of the literature, but also how we're addressing that with our patients. Now, I downplay that a little bit from that perspective, but we bring it back around because that's very, very important to what the patients think is, we still need to make sure that we address that. And I'll sort of, talk about that as we move through. But so we're attempting more so to get into protocols, right? So your parameters are going to be the settings that you use, the dials, woo woo, kind of setting up again what you already know. So think about that if you haven't used laser or shockwave, but you've used neuromuscular electrical stimulation, or I should say E-stim, in what is your desired outcome, and that's really what helps you sort of set up those parameters. And when we look at these particular devices, and I'll call them modern because they're more being implemented much more recently than some of the other ones, although it has been around for a while. Why are we listening to me? So I've been using laser for 20 21 years or so, and shockwave for about 16. Um, and obviously using those two things together from a clinical perspective. And so again, the big question is why or when do I want to use these, and is it consistent? And to some degree, it might be, and that's where the protocols establishment actually comes in. So again, we're moving away from what we've been obviously focusing on pain. You don't want to do that because that's going to limit your ability to retain those patients once you get them out of pain. But more so looking at the dysfunction a little bit less with regards to what it is that we're seeing as a diagnosis code, and I'll talk about that here in a moment. So we're using limiters or outcome anchors, right? And if you've heard me speak in the past, the last several years, really kind of digging in and using those particular terms. One, because they're simple and easy, they can be at least, but they can also represent the things that matter more so to the patients, and it helps guide us, clinically on that day-to-day basis, right? Because we can't just create, and I've done it, we can't just create, an 8-week program and necessarily expect to stick to that because stuff happens. I always use the example of, I was working with a law enforcement officer, and they would come in and, oh, how you do? Oh man, I'm not good today. And it's like, well, is it my fault or what happened? Well, they were chasing someone down and they had to tackle them. So there are things that can affect that, and that could be a limiter. And then the anchor is going to be, what are the things that are working, what are the things that are not working. So we'll get into that. We'll talk about the modality selection, and I'll hint at some of these other things. And I don't want to imply that laser and shockwave are the only things, because we have a whole suite of physical agents, and there's overlap in some of those things, and that impacts, some of our choices. Okay, so after pain management, we still need to address pain. If we don't address pain, we're missing the opportunity to dig into the psychology of why patients think they came to us. right? So when we do dig into that, we find out that patients actually came in because of a limitation, a dysfunction, right? You're asking them during the history, the intake, what brings you in today? Low back pain. Well, how long you had that? 5 years. Why now? Well, now they can't do something. So it's gotten to a point where they need to make a change because that thing, that function, that dysfunction is now what's causing them to be very, very problematic. So we also look at, not trying to change everything all at once. I equate that to, I don't travel quite as much as I used to, but I would benefit obviously from an expense account. So, going to different restaurants and I would often replicate whatever it is that I liked when I got home. And with a recipe, if you change too many things all at once, then you don't know what worked or what didn't work. And it's very similar here. Now we're creating those guidelines, right from the beginning. So another touch on pain, why I have this journal of pain thing down at the bottom. This transition in what we're seeing, the psychology of pain is it's at least interesting. And I remember being in a chat forum, and there was a new grad, and he was hounding on somebody else. And I'd say, stop me if I've told you this before. I know I've told to some people before, but you can't tell me to stop it anyway. But basically, he was saying that treating pain is simple. It's like, well, it's as I, tell people, simple physics. If you're a physicist, then yes, physics is going to be simple. And so there's a whole, area science of pain or pain science. And so, digging into that is also going to be important in trying to figure out what it means to the patient, what it causes in terms of limitations and what they're going to do or what they're not going to do. So we don't want to change things too often. We definitely want to deal with that aspect of pain, but we don't want that really to be, the largest anchor, because once you get someone out of pain, where does it go from there? And if that's your anchor, their anchor of coming into the clinic, then that's going to be problematic. As we know, the statistics in outpatient care, hyper focused on pain, they do not complete their course of care because we get them out of pain, and that's what they thought they were there for, and so they're not really there for the function. And then if there are flares, what is the next step? What can we actually do? I put over here this other graphic, the trans-theoretical model. Um, I'll probably butcher the name. Prochanska and Di Clemente established this, I think it was back in the 1970s. So we used it in smoking cessation. We use it in fitness. So we use it in other areas of health. And I kind of joked and created this other model for decompression therapy, right? Using spinal decompression devices, mechanical traction with the intent of creating negative intradiscal pressure, blah, blah, blah. And that, it's a 24 visit plan. And it's like, well, does everyone start at day one? And the answer is no. It kind of depends, where they fit within that sequence. And that's where the trans-theoretical model kind of works, and where, someone who fell off the wagon, they had a cigarette when they were attempting to quit. Does it mean they need to start back at square one? And the answer is no, because they've already gone through these certain stages and they can just kind of jump in, to that particular level. So same thing with our treatment. It basically means we don't have to go back to square one. Where does it fit back in there? Kind of like the law enforcement officer that I was referring to. I don't need to go back to square one as long as they weren't brought themselves all the way back there. But where do we need to go back to? And again, that's part of the art of all this, unfortunately, is it's not as simple as just maybe plugging in. And so, patients present with these limitations. And what we've been doing, especially over the last 10 years or so, is not just digging into the diagnosis. And in fact, we've even seen, the ICD classifications change. We've got more of them that are related to function, or I should say, dysfunction. And I've always used the example down here. So there's an article by Ghost et al. In 1998, and it was on spinal decompression therapy. And if you look at what they had for patient population, now it's not a randomized control study that would have changed things, but it's a retrospective case series. And the age range was 18 to I think it was 72 or 78. and basically I'll have the same diagnosis. Well, yeah, they may have the same diagnosis code, but I promise you, an 18-year-old is not the same as a 72-year-old, or even just looking at the mechanisms associated with what, part of their problem is. And we often, kind of jump to the label of like chronic low back pain. Oh, well, it's chronic. That's what brought them in. Therefore, I immediately deal with, a protocol that delivers a chronic um, set of parameters. And in a sense, that might actually be more problematic, and you could create more issues for the patient if you do so. In fact, I was just contacted by a colleague of mine out in California, and he was asking me about decompression, and he was just seeing a patient who was pulled too hard, who ended up with Cauda-Equina syndrome, and subsequently in the ER had surgery 24 hours later. Now, he's not saying that it was because of the person themselves, but it sounds like they did potentially overtreat when not getting all of that. Yes, chronic low back pain, it's a chronicity. They've had it for a long time, but what stage are they at? Like, what's going on inside? And well, if we could look inside, then that would be great, but we don't. So we have to take various types of studies and tests that we might not be able to see inside, but it might be a performance-based outcome measure. So we need to make that consistent with what it is that we're doing. And that's the challenge is we can't see inside all the time when we get some of these rather sort of acute exacerbations. I'm not getting into the physiology of laser and shockwave, and I know many of you are probably going, "Oh, thank goodness," because I like to dig in because there's some really cool stuff in there. But for this purpose, let's make sure because we're really talking about setting criteria. So the first thing we do is make sure that someone is not contraindicated for these particular treatments. And that's where I always start. So when someone first, calls me up or sends me a message and they say, "Man, do you think laser would be good for this or shockwave would be good for this?" And I said, "Well, let's first start with, do they have any contraindications? Or where are you going to be doing that?" Right? And so definitely screen for the contraindications and the precautions, right? Just like the example I just told you about, when we're dealing with someone with, a neurological attachment to their low back pain, I definitely want to think about that because knowing what I'm going to do to them is going to be important, right? So that would obviously be a precaution. And I don't know the whole details of this particular person. Maybe they had some form of stenosis, especially if it was bony, then I would definitely want to be much more careful when I might be delivering that, or I might not want to do it at all. So screen for, these contraindications, um, and, kind of be as detailed as possible. So obviously malignancy in the treatment area, really for both of these, is going to be a no-no. And then the other big one I always get, which is going to be pregnancy. Now, we can treat a pregnant person with both of these devices, just not in the area of the abdominal pelvic cavity, especially to the anterior. And then people will say, "What about the posterior? Because that's not in writing." I say, "Well, you might want to, be careful with that. If I'm going to be in the lumbar region using something like shockwave, I might want to be a little bit more careful and take that into consideration and use a potentially lower energy density, or maybe not use it all. And it depends on your level of comfort and your ability. So I'm not going to go through all of these. I mean, they're in the IFU, which stands for intention for use. And so that's your user manual, in case y'all forgot that. I know I'm horrible at reading those things as well. So looking at it from the limiter perspective, like what are some of the things that are going to help, create the dictation of what exactly it is in terms of the differential. In other words, choosing a non-contact, non-mechanical form of energy, such as laser, or choosing a mechanical form of energy, right? So even though shock wave creates an acoustic wave pattern, once it hits the tissue, it becomes mechanical in nature. Okay. And so with radial extracorporeal shock wave, remember that that energy density is going to be highest at the surface, right at the applicator as you put it on top of that patient. And by the way, also within those dermal layers and subsequently below that, there's a lot of free nerve endings. And so they may not like being touched or poked or hit with something that is overly, pressurized and mechanical. So irritability and sensitivity. People that tend to be in really high pain, people that are often guarding because of high pain. Now, guarding's a potentially another scenario that you can take under consideration. Like, is it a muscle spasm? Is it a hypertonicity? So we're going to say guarding. In other words, almost the adverse reaction to wanting to move or use something because of the high level of pain. Low tolerance and flare up positions. In other words, I put them into a specific position and that causes a lot of pain. And that's like I use that one a lot in particular because we want to put people in their comfortable position. Someone just asked, "Is this being recorded?" It is, so you'll have the wonderful benefit of listening to this again if necessary. So those flare positions can be important. And dealing with one now, they wanted to send this person out for an MRI. And I'm like, well, she has horrible posture. She does not experience any pain during her recumbent positions or lying down. It's really only going to be when she's actually moving. So think about, those and maybe what does that mean? Well, I can't really ask you the question, but what does it mean? Again, I probably want to use something that's going to be non-contact. I use this low tolerance thing a lot, and it's also respective of the psychology of your patient. And this is where I kind of get into, and I talk a lot about patient management, regardless of, the potential device. And again, those are some of the points that we take under consideration. So what do I mean by that? Well, I've got a new patient. I'm a chiropractor, never been to a chiropractor, um, not really sure, what the experience is going to be like, heard about things, whatever, but not adverse to being treated, but definitely an unknowing. And that's where, utilizing some of those therapies that are otherwise a little bit more comfortable to deliver, and creating that rapport and that trust with the patient. And that's why the limiter in A, should be kind of your go-to with laser. So laser is not going to irritate from a mechanical standpoint. You're not moving the patient around. It's usually, in fact, very, very comfortable, especially high intensity laser therapy, because it can create a warming effect, which again, we're not going to get into the physiology, but if it was acute, would I want to use something? Well, it's not increasing tissue temperature, like you are with therapeutic ultrasound and shortwave diathermy. So that makes people feel really good. And if that initiates that relationship with your patient, I find that to be extremely beneficial, because if they are a potential patient for us, we don't want to lose them. Then the interface driver. So we looked at, what is their pain? What does their response look like to the delivery of something? And then what are the problems that we're dealing with? And so we're looking at, tendon, fascia. Do they have localized pain or discomfort on load? So I just said, when someone is standing versus lying down, what are the mechanisms associated with that? And potentially what is their problem? And then the chronic tissue behavior. One of the things we see, for example, in low back pain is we see adiposity or fatty infiltration of tissue into the paraspinals. And if they have this chronic back and forth of inflammatory bouts, then we also start to see, deterioration of especially the intrinsic musculature. And then there's a whole, neurological effect to that. So taking those things into consideration as well, and what, might be most opportunistic in terms of the treatment, and then limiter C, the capacity or the strategy. Again, this particular patient, they wanted to send for an MRI, 86 years almost 87 years old, frail, um, mild cognitive impairment. And I'm like, okay, so if you determine she's on, I think, 12 or 13 different medications, amitriptyline being one of them for over 60 years. Yes, you heard me right, 60 years. Um, that in and of itself can be problematic. And it's like, well, you're not going to do surgery on this person. Very, very deconditioned. And how does that impact the overall strategy? The movement strategy limitation. What are some of the things that they can't do? What are some of the things that they don't want to do? And especially in things like activities of daily living, what does that look like in terms of some of the deficits that we need to deal with, and how does that impact, what might be going on? Um, Anchor menus, right? So these are the things that we talk about in terms of based on their condition, based on their pathology, based on their limitations. What things can we use? I talk about plantar fasciitis all the time. It reminds me of talking about ACLs. I just had this discussion, with a group of students, and it's like, why do we talk about ACLs so much? Well, it's problematic. How many do we actually have? And of course, students in the classroom all have their computers out these days, and so they could fact check me, as I'm talking. And it's like, well, we only have about 100 to 200,000 of those a year. So population wise, it's not extensive. Same thing with plantar fasciitis. It's not even in the top 10 um, of codes that, your typical outpatient physical therapist, a chiropractor is going to see, but it resonates with a lot of people. First step pain. Why is that one so important? Well, when I hear that from a patient, I immediately will go to laser, right? It means that they don't load tolerate um, very well. And so their tissue, not bueno, no bueno, not good for, really using a high mechanical energy. And so we find that laser is going to be, basically our go-to for things like that. So these are just some of the examples of anchors that I have for plantar heel pain, tendinopathies, knee OA, low back flares. So they're all, kind of specific. And so there are examples of some really simple and easy things. Like for the knee OA, doing stairs. Is it more painful going up or is it more painful going down? Can they go from a sit to stand position? Watch them, by the way, and look at their strategies when they are getting from a seated to an upright posture position. What does their gait look like? We find that although some people can ambulate very, very well with severe knee OA, it's because they're using very severe strategies to accommodate for that. And so I want to take that into consideration because those are going to be partly my anchors as well, because I do gait analysis. What does it look like as I'm treating them, and what are some of those changes that we're going to see? So what we don't want to do is we don't want to add modalities without some metric, like what exactly it is. Now, I get it. We can look at the plausibility. So I know the pathology and the pathogenesis of this particular condition, and here's what my modality can do, and we kind of match them up. And I actually start there, right? But that can be very challenging, especially in dealing with the patients and explaining to them. And so I have a tendency to use very interesting pictures here. So I was getting my hair cut yesterday, and I go to a barber, and he's telling me about he just went to this new clinic, and he's in really really good shape, rather young guy, and mostly it's just these little things, and he needs to keep himself moving. He's got a young son, so they do a lot of things like motocross and jet skiing and skiing downhill and so on and so forth. And so he said, I went, and he's like, I said, dude, why don't you come see me? He's like, well, you don't take insurance. And I said, well, I get it, and that's a whole nother discussion, and I get why he wants to do that. I've actually treated him in the past. He's a funny dude. Like he didn't want to barter, so he doesn't like owing people stuff. So I would treat him, and it's like, okay, I get a free haircut, the next two times or whatever the case may be. But in any event, he's like, he goes, it was great. They spent a lot of time with me. The second time I went back, he's like, they didn't even talk to me. He's like, they didn't even ask me anything. they didn't test for anything. They did exactly what they did the other day. And he's like, he goes, I stopped them. I said, listen, don't just do stuff because you're going to charge my insurance or I have to pay for this cash. And I'm like, oh man, you're a pleasant patient. But and so in other words, making sure that we have anchors that, you know, also the patients understand, because in those cases, and in particular with laser and shockwave, they're not reimbursable. And so we need to have some level of justification of, why they're paying for these things. And one, if you're getting them out of pain and that was your anchor, that's going to be problematic moving forward when, there are typically dysfunctional patterns that are going on. So, as I mentioned earlier, when irritability dominates, laser is typically favored. Laser works so well biochemically. It's comfortable. In my case, it's also hands-free. So the workflow is there. In other words, I can either treat another part of the body or go treat another patient while that patient. So in other words, it's an unattended therapy in some cases. Very broad spectrum types of pain, which typically means, you know, what's causing that is multisystematic. And so, again, laser can address multiple tissues at the same time. The interface drivers, as we talked about, with like, tendons, ligaments, muscle tissue, especially if there is a mechanical problem, a mechanical type of application tends to work well. Now, there's the combined effect. And so we did a webinar on this in July of 2025. So you can go check that. And we don't have a ton. We've got some literature, and that's kind of cool for some of us that have maybe been doing this a long time, and to see maybe that we're not just crazy, and we're seeing the positive aspects come out in the evidence too. But maybe there's also an opportunity to combine some of these things if maybe there's two things going on. So there might be a lower level of irritability. I mean, think about that chronic low back pain patient that comes in, or even the knee OA, which is obviously also a chronic condition. Do I really want to just get after them with a mechanical form of energy, or maybe I need to potentially address the biochemical aspect and/or apply the mechanical? The other thing to consider is, again, what these things can do for you. So laser's been shown to increase ultimate tensile strength of tissue, ligaments, even before we start mechanically loading them. So it's a really, really good precursor even before we start doing some of that mechanical stuff. So looking at the tolerance and also the stimulus that we want to deliver, and again, relative to these anchors, which could include the irritability along with some of these load tolerances. Um, and then it's the painter in me, the artist, that says sometimes I want to be more aggressive. And that may be dictated by the type of patient, what they do for a living, whatever their capacity. I live in an area where a lot of people come up and they're on vacation. And so sometimes it's about getting them through so they can at least enjoy the rest of their vacation um, before they head back home. So is it same day or are they different days? So again, you can go back and look at that other one, and we talked about the simultaneous or the sequential nature, right? And so the same day activity of using both of these, let me take a step back too. So when we first started seeing, the literature on combined types of physical agents, it was pretty limited, especially using some of these low power. So I quote often a study that they evaluated the individual or the combined of laser, and it was low power laser, E-stim, or therapeutic ultrasound. So each one individually and then each one combined, right? And they essentially found no difference. And if you don't understand, what that actually means in the nature of patient care, it's like, well, the E-stim took 20 minutes. The ultrasound protocol took 8 minutes, but the laser took 90 seconds. So even if it was a wash, well, why would I want to choose laser? And the reason was because if it was just as effective, but it only took me 30 to 90 seconds, and that was again for that minute little area, a low powered laser, then that's part of your choice options, right? So same day appropriate when the tolerance is predictable. What do I mean by that? It means that I have a certain expectation of what their discomfort level is going to be when I'm applying radial pressure shockwave and the potential side effects of laser or shockwave. And so when we know what that's going to be, and really it should be very minimal, by the way, right? If we induce increased edema formation, lots of petechiae, you probably overdid it. And I'll still have people argue and say, well, that's what's working. It's like, well, if you've ever tried less, you might actually find it will work a little bit less. So during these phases, we're still seeing in the literature typically one time a week, especially if you're going to be aggressive on the shock wave. But where laser can still come in and its potential benefits, especially during those times of higher irritability, is it can help facilitate those biochemical changes, right? That's where it tends to be really important and can potentially elevate, as we talked about in the previous webinar, as the literature showed us. Split day. Well, the split day is if one, we're not trying to introduce too much energy, or we're actually trying to facilitate a recovery from that particular therapy where we're not doing them on the same day. I will throw out the other thing too is how you manage your time and the typical, duration of a patient visit, and sort of your model. Like how many things can you do to a patient within a single session is also something that you're probably going to want to take into consideration. Yes, and I think Josh just posted that. You can put if you have questions. We'll have time at the end here to go through some questions if you have them. Okay. So irritable start. This is I'll use the example of that low back pain patient. The low back pain patient comes in. It's an acute exacerbation of their chronic condition. So that's an irritable start. So we probably would also classify really any acute type of injury in there. And so in that irritable start phase, again, laser's so good biochemically without creating discomfort to the patient. So toleration is typically, very, very high, right? So oftentimes I won't even start with shockwave until we get past that phase. And that's often going to be 1 to 2 weeks, right? So we've been able to manage that inflammatory state, and create that rapport with the patient. So the first 2 weeks, I may not be doing any shockwave. Now, is that always? No, because some people are going to be a little bit more tolerable than others. And frankly, I want to get to shockwave as quickly as possible because it's a time frame and I want to get people better as quickly as possible. And if you again consider your management profile within your clinic, if you're classic, 12 visits, we want to make the best out of however many visits that we possibly have, right? And so once I hit typically that third week, that's when I will start doing the shockwave. I always do a wean off on the laser. And so the benefit of that is sort of understanding what people will do at home. I call that the Zumba effect, and I probably tell this story every single time I present. But you know, patient feels better when they leave. They come in the next time. Oh man, I don't think this is working. Really, well, I don't understand what happened because you're doing great. Yeah, I didn't do anything. I went to Zumba when I got home, and it's like, well, you weren't supposed to do that, right? Because that was a load tolerance effect that they were not ready for yet. So laser allows us to sort of taper off, right? Laser is also really good at pain. So if they still are in those stages of pain, it tends to work well. So the other reason for the taper with laser and then the increase in the shock wave is the patient psychology of it. They need to see changes. If you're doing the same thing every single time, day in and day out, just like I told you about my barber, that can be problematic for some people, right? And so this actually shows changes when we stop doing something and then we start doing something else. And I'm going to talk about this in the documentation of even just shockwave in a moment here, but also I let people know like what it is that we're doing. So when I make changes to some of the parameters, I'm even gonna let them know, and I'll talk about that in a second. Now to the interface, right? So this is the type of tissue we're beyond that biochemical stage, and this is where again I'm going to go into shockwave. And so typically, my pattern is going to be once a week. If I'm less aggressive, especially during some of these earlier stages, we can get into twice a week. A lot of that comes from the erectile dysfunction literature. So the reason that that literature is really, really good is it's very well controlled. Um, and so what they found was you could get increased benefit doing it 2 times a week. But is it that much different or is it that much better for you? So you have to be less aggressive. And I don't mean just in the erectile dysfunction, but really any part of the body, because you don't want to create an inflammatory response, right? And this is also where laser comes into play because you are in danger of doing that. And again, it depends on the patient, and this is where it could be 0 or 1 time a week, typically matched with the day that we're actually doing shockwave. And then those that seem to be the tweener, right? They're sensitive. Maybe we're making some changes. Maybe you added exercise therapy, which uh, can induce some increased soreness, especially if they're doing high intensity stretching and things like that. We want to, again, use that potentially as an anchor, and you need to segregate or separate that from a flare up, right? In other words, delayed onset muscle soreness is going to be different than what we would see in terms of a flare up where there was an inflammatory stage that kicked up. Uh, just again, because of the evidence aspect of things, to put these in here that um, we do have really good supportive literature on all this stuff, and it's in both, and that's where I think the other challenge is when people have both of these devices. Now, let's say you only have Shockwave. Well, what can I do there, Chris? Well, it could be that you're using something else to potentially mitigate that biochemical response. Maybe it's your ultrasound, maybe it's your e-stim, maybe it's your shortwave diathermy, whatever your choices are, think about where they plugged in. And again, that's just part of knowing what we need to know, right? So we see this in all of these for both shockwave as well as laser. And feel free to shoot me a message. I put together some compendiums on even comparing radio pressure versus focus shockwave, and we can have a discussion about when I choose to do which one of those. And then the high intensity laser. This is, you'd think that we're done, we're not. We still have a lot to kind of work through with regards to laser, especially high intensity laser. With these higher powers, there's more responsive. No, there's more opportunity, and that's where some of these wavelengths come in, like the 1064. So you do need higher power to deliver that, and the benefits that you can get from that. So again, we've got really good supportive evidence. And we're also seeing the body of evidence grow on, when we're combining both of these therapies as well. So here's the other challenge. Chris, I saw a new piece of literature come out, for a condition that I'm going to start treating, whatever the case may be. Can we create that? And the answer is yes. Like, I would probably never buy a device that didn't allow me to manipulate that. At least in the clinic unit, I get some of these portable ones that can be nicer, to just press a button. And we still have all that as well. So the parameters, when it comes to both laser and shockwave, we're looking at an energy or an energy density. We're looking at a frequency setting, and we could be looking at the total time or the total energy, which in the case of laser is going to be in joules, and in shockwave, it's going to be the number of impulses. And obviously they overlap to give us the energy flux density, the amount of energy that's going to be delivered to the target tissue over that general time frame. Now, the cool thing is there's not a lot of parameters that we really need to think of. The uncool thing is, like, laser is a little bit more challenging. So I had someone ask me about, oh, I don't need presets because that means I'm not a good clinician if I don't know which one to use. I'm like, yeah, you just really kind of need more of a basic understanding in terms of more energy, less energy. Do I need a frequency setting? Do I need it to be continuous? What are your wavelengths? What are your favorite wavelengths? What do you want to use for various types of conditions, right? Knowing the 4011 protocols that, I developed for the products doesn't make you a good laser clinician. It makes you a laser specialist, which is a little bit different. But with Shockwave, it's a little easier. Um, but even then, it's not specific to a tissue right now. And then, well, what if the literature is in bar versus millijoules? That's where it gets challenging because bar is a pressure setting, right? It's a conversion of like PSI. So 1 bar is the equivalent to about 14.95 PSI. So that's just a pressure setting as it's coming out of your device. That actually doesn't necessarily translate into the tissue. Now, if you have an understanding of your device and you know the surface area and the actual force that it's producing over a given surface area of your applicator head and over the tissue, then you could potentially, calculate your energy flux density. Yeah, most of us don't really do that, and so we kind of just go, at least today, we're still seeing that patient tolerance is a really good indicator of the potential higher end of the benefit, right? So that's sort of the upper echelon of the spectrum. And then what do we know below that? Well, we actually know that you do not need a lot of energy to create a biological response to the tissue. And that's very important to understand because what I say is you don't have to kick the crap out of your patients just because the literature is such. I was giving a presentation to a sales group on cervical traction, for example, and I'm like, yeah, you can start at 8 pounds, in a low coefficient friction design system, and everyone was freaking out because they're like, well, Medicare requires it to be. Blah, blah. I'm like, yeah, you can progress to that. You don't have to start with that because that might actually put them over the edge. If you hit someone too hard with these devices, you can flare up. They may not like that. So we can actually use a stepwise approach, which we'll look at here in a second. This is quick and dirty. So this is looking at what does a bar setting look like? And this is the linear translation. And so um, at zero point 0.5 bar, that's about the equivalent of 20 millijoules in most of the electromagnetic devices. So what we see is the pneumatic devices tend to use a bar setting. As I mentioned, that was PSI conversion. And the electromagnetic devices, it's easier to calculate because we're dealing with energy conversion. So I can actually use millijoules, and that makes it a little bit easier, right? So this is not. I don't want to mislead you. This is not a complete true conversion because there are other factors related to that, which is going to be the size of the surface head. Even the pneumatic devices, not all of them are created exactly equal. So this is the ladder I was talking about. I typically start with 500 impulses, and that drives people crazy. And they're like, well, that's not enough to do anything. And my typical response is, oh, yeah, why not? And they can't answer that. And you can't answer that because you'd have to quote literature, and the literature will show you that, it does not take a large volume of pressure to create a biological response. In fact, one impulse will do something. Now, is that enough to do something that we're looking for clinically? Probably not. But 500 impulses is really good opportunity to, one, be clinically relevant, but also test the waters. I never want to make it worse on a patient because then they have a tendency not to come back, right? So remember that whole relationship and that rapport thing that we want to deal with. So typically, we're going to increase in the volume, the number of pulses, before I'm going to increase in the intensity, right? So this is what I'm getting at here. Treatment one, 500 impulses, 60 millijoules at 12 hertz. Then I'm going to go to 1,000. Then I'm going to hit my target. Usually within 3 visits, that's going to be my target. And typically it's 2,000 impulses to 2,500 impulses. Okay. Now I can increase with the energy density. So here's what's interesting too, and why this I think is important to explain this to patients is um, yeah, you're increasing, and that's actually clinically relevant. And you can say, well, how is that clinically relevant? People that are in chronic pain, we know that there's a decrease in the threshold at the DNA level to nociception. So when I can increase the intensity and not have side effects to that, it also means that we're literally changing that threshold. And that's clinically relevant. And I explain that to the patients because now in their mind, they're thinking, oh, I am getting better, right? And it's kind of tying back in one aspect that they're at least thinking about, which is, oh, I'm out of pain. Now it takes me more energy to put me back in that same pain situation. So now my tolerance, right, per load is actually going to be increasing. So the stop rules are when we start to see these repeated flare cycles. And again, sometimes you don't know, and that's why we don't just have this steadfast rule of all these protocols. You might have someone who's more sensitive. You might have someone who's also, I won't say on an anticoagulant, but something that might affect. And let me tell you, it's not just anticoagulants that can affect that, but all kinds of medications can have an influence on what might result as a flare up. So we always go back, we reassess, we look at our targets, and we think about what it is that we're doing. So then for laser, we might do a couple things. I could potentially increase the energy density, right? So a lot of these devices have presets. I often start and I do a half to kind of develop and see. Now, again, it's a high intensity light, and so do you know if they're photosensitive or not? I mean, obviously, we're going to ask them. Sometimes people don't know till after they've been treated. Sometimes, yeah, we told them not to put any lotions or things like that on. So we can start with a lower energy density, and I promise you, relative to the lower power lasers we used to use, cutting a treatment protocol in half is not a bad start, right? And again, I don't overemphasize the whole pain thing. As you might imagine, I talk more education wise and explain to them, why we're also doing that, right? So we may increase the area, especially if we're dealing with the pain in the early stages, and then we actually tighten it. We stick to the pathology. As I kind of tell people, like, think like a surgeon when you're using, laser and shockwave beyond that pain level, right? And really just address that tissue, right? Because you can use some higher energy densities. It's going to decrease your treatment time quite dramatically. But what about these secondary areas? And this goes for both laser as well as shockwave, right? The typical, like I'm treating a lateral epicondylopathy, I'm treating over, where do I do? Over the boo-boo, right? But it's not uncommon that they have some issues going on in adjacent structures, maybe the wrist extensors, for example. That's where I may go off and do an adjacent area with the same device, or at least addressing those devices a little bit different. So I'm just going to quickly run through these. So these are some examples looking at heel pain. Like I said, first step pain is a typically a dead giveaway. Yes, you maybe have done this and you got away with doing shockwave on that. That's absolutely fine. I've learned that I just go straight to laser and I don't take the chance. And so when we see that first step pain go away, that's my key to say, okay, I'm going to move and now I can start adding that shockwave in, right? So dealing with that high intensity, the sensitivity, the irritability from the inflammatory, that's why we're going to start with laser. And once that first step pain goes away and they can have a low tolerance that tells me that, yep, I can use a mechanical form of energy, we can go into that. Secondary, then I also start to think people typically with heel pain, plantar fasciitis, have issues in adjacent structures, right? So I'll go up to the gastrocsoleus complex and I'll look for some of those other problems. And then, like, unfortunately, this is way beyond the exercise therapy piece, but I'm not just doing shockwave and laser on patients. There could be manipulation, there's exercise, there's, all of these other factors. Typically, I'll start with laser, then I'll do shockwave during the earlier stages. Once we've gotten past that first step pain situation and we have some relative low tolerance, I'll get into and I'll start doing Shockwave, and I'll taper off and I'll do laser after the fact. And then tendinopathy patterns, it's actually somewhat similar. So when they have extreme pain on any sort of loading of the tissue, I mean, not just point sensitive, but loading the tissue, right? And it could be a task tolerance as well. Again, that's where laser comes in, especially well during that early stage. But otherwise, if they don't have that, and it's not a biochemical inflammatory stage, that's where I actually do. I like to go directly to shockwave. And if we are being more aggressive, then we are going to use some laser on top of that as well. There's always typically a taper to laser when I'm doing that. I just had to show you this one. I'm looking over here. I'm circling my cursor around the anterior glenohumeral joint on this right-sided picture. Huge amounts of edema in this area. He came to me. He was seen at the orthopedist office. He was told that they were going to give him the award for the largest calcific tendonitis they've ever seen. It's in a supraspinatus tendon over here. Excuse me. So this is a really good example where he had this inflammatory stage, and so we did both laser and shockwave. Now, he very point sensitive, and of course, if you've done this, you know that over bony prominences, it can be a little bit uncomfortable. But here's the thing: he presented, had that inflammation, and he had no abduction in the first 10 or 15 degrees, and so, but it wasn't painful, and that again is why I went directly to starting with shockwave, but also with laser um, during the same treatment session because he even have that visibility. Um, I treated him twice. He went back to the ortho for the follow up because they were looking at injections and surgery, and the ortho was blown away. He's like, I don't know what it is that you're doing, but whatever it is that you're doing, his range of motion. He let him go back to cross country skiing, light immediately, but yeah, it was that fast and that rapid. And here's the problem too. He's like, I think I'm done. I'm like, no, you're not done. This is really the size of your calcific tendonitis is such that this could take 10 visits, and trying to explain to him that it just wasn't about the pain and that, the reason we kept doing the laser was because we initiated some higher level activities and I wanted to make sure that we could mitigate sort of any inflammatory issues. The NEOA is a really interesting one. Once you get into that cytokine cycle, it's very problematic, right? So people with chronic knee osteoarthritis, osteoarthritis in general starts to almost act like an autoimmune condition. So that's where I think the laser biochemically does really, really well. Now, Shockwave is also an anti-inflammatory and a COX-2 inhibitor. So great, match when it comes to that. So what am I using? Again, climbing stairs, sit to stand is one of the most basic ones. It's also something that we find, getting out of a chair is real important from a functionality standpoint. So if I can, I will go to maximize our visits because if you get them way late, your chances are, they're going to be reduced if they have a whole lot of destruction going on. But the sooner that we can get them, and I like to get them as functional as possible because I need them to be doing their exercise therapy. We know that just increasing the quadricep strength and the hamstring strength is going to be beneficial. So really getting into the shockwave and laser right off the get-go. I often do the laser first because this is one of those where low tolerance or not, most people are still going to be walking around and they're in a lot of pain and they're irritating that tissue. So we really do kind of need to get into that. I threw in low back pain just because a lot of people here treat low back pain. This is one of those where typically people present with an acute flare-up of a chronic condition. I will often start with the laser decreasing that inflammatory cycle and then I'm often doing decompression at the same time. I want to get to the adjustment as quickly as possible as well, which is the other benefit of managing their pain as quickly as possible too, and limiting the effects due to that inflammatory cycle. Now, again, I couldn't get into. Maybe in a couple months, we're going to get into a little bit more detail with regards to the biochemistry and the physiology regarding what these devices do. But Shockwave is actually very chondrosparing, neurosparing, myosparing. So it is something that I want to get to as quickly as possible. Um, the the documentation. So what I was referring to a little bit earlier, I think this is really important because this is also going to help us in terms of communicating with the patients. But I won't know if they're flare-ups or if it's just a reaction or a response to something else that we might be doing. So that's where I think it's really, really important to utilize and make sure that we're using our documentation as best as we can. And I think I'm just about out. I am out of time. Holy crap. So we've got three assets, so you can communicate with Josh. And so I've got some algorithms that we use, which basically is everything that we just talked about. Um, with all these different key takeaways, looking at the sequencing, looking at the rhythm, and then looking at the documentation. What do the targets look like? How do we, potentially increase and build some of these protocols? So that was a quick wrap up. Let me go to the chat and see if there are any questions here. So feel free to write something in the chat. I know we're over time. A lot of you got to get back to treating patients. So I will say goodbye to some of you if you can't hang out. And I look forward to seeing you next month. But definitely reach out if you want those assets. Just looking at the workflow. I'm also happy to share these PDFs. If it can help you, maybe you can create some marketing materials. Maybe you're going to give a presentation to someone about the clinical application of some of these things. So definitely feel free to reach out uh, at Medray Laser, and happy to share those documents with you. Other than that, wherever you are in the world, I hope you enjoy the rest of your day. I hope the weather's good for you. My kids are on vacation this week, so we went night skiing Tuesday night, which was a lot of fun because it wasn't brittly cold out like it has been. It's been a really, really cold winter, but we've been getting some good snow, so that was a lot of fun. I did feel like I needed probably laser and shockwave over my entire body after that, but it was fun. So anyway, I appreciate you all. Feel free to reach out if you have any questions.